A warm welcome to everybody to the first edition of K-Care Chat with Paula and Nat, where we hope to find the answer to all of your questions. Now, you've joined us for the very first session in our Pressure Point series.
Thanks, Paula. It's so exciting to be here, and so exciting that K-Care has supported us with this opportunity. And the most exciting part is our guest speaker, Tracy, who is the guru in pressure injuries. I'm not sure if you all know her, but Tracy has extensive clinical experience as a clinical educator, really strong focus in client engagement and providing best outcomes for patients. She specialises in pressure injuries, in falls prevention. The most exciting thing is that, in my eyes, is that she sat on the steering committee that developed the Pan-Pacific Pressure Injury Guidelines and the review of the Global Pressure Injury Guidelines. I mean, who best to answer our questions on pressure injuries other than Tracy? So welcome, Tracy.
Yes, Tracy.
Hi. Thanks for making today possible. I really appreciate the fact that both of you had such a vision and a hope to support the clinicians to be able to understand pressure injuries at a deeper level. So I really thank K-Care for making today possible. And I know it's a lot of work from your end to make this all happen. So thanks everyone for joining in. And we're all on a time limit, so I know you're all busy. So we want to try and keep this to about 20 minutes. And I'm going to give you some dot points. So there's a couple of things that I really want to make sure that you take home with you.
Excellent. We've got a couple of questions. I think Paula's got the first one. So
yes, we have. We received a question from Christina in Queensland. Thank you so much, Christina, for the questions. So Tracy, how do we classify pressure injuries? And what updates and changes have actually been made to those classifications?
Okay, so the changes have been happening for many, many years, and it's as research has developed, we've started to understand pressure injuries at a massively higher level than we ever have. So there's a lot of changes that have happened, and I'm just going to give you some dot points around that. And, you know, go Australia, you've done an incredible job of embracing the term injury. So if you go back into the 80s, we were using the word decubitus ulcer, and we all thought we sounded very important because the patients were clue what we were talking about. It sounded very important. And the term decubitus comes from the word to lie down, right? So that's actually, we know that you don't just get a pressure injury lying down. In fact, you're at higher risk when you're sitting up. So decubitus didn't really work for us, and ulcer didn't work for us either, because it didn't take into around about 80% of our pressure injuries are either a stage 1 or 2. So 1 is not, the skin isn't even broken. So it's nowhere near being an ulcer. So the term ulcer didn't work. So we went into the term injury, and everybody just grabbed it. I'm so really, really pleased about it. But the Americans were very hesitant. And it was in 2016 that they finally came along with us into the term injury. And the reason they were hesitant is the term injury in the Oxford Dictionary means a wrongful action or harm to the body. And so if you drive around their country, they have these massive billboards that say, did you get a pressure injury? We'll get your money. And so they thought it was sort of confessing litigation. And they've now come on board with us. And Europe is still using different terminology. But Australia has, since 2009, we brought that in. The Pan-Pacific, Australia, New Zealand, Hong Kong, Singapore and China have all come on board with the term injury, and everybody loves it. So that is number one change, is bringing in the term injury. The other changes are that we went from 4 stages to 6 a while back, which was bringing in the 2 temporary categories, unstageable and deep tissue. But in the new guidelines, the next stage came along, which was mucosal. Now, there's a reason why there are 3 categories now. So it's a bit of a trick question when you say how many stages. There are still 4 stages. But now we have 2 temporary categories. So they're temporary because a suspected deep tissue and an unstageable don't stay there. They eventually go into these 4 stages somewhere. And we don't have enough data to tell you how many unstageables become stage 4s or become stage 3s, how many deep tissues, which is intact, and then eventually erode, do they become 2s, 3s or 4s? So that's another topic that we'll follow more closely. And then this mucosal that sits on its own, the reason it sits on its own is it doesn't, it doesn't have an epidermis. It doesn't usually have a bony prominence. It doesn't behave the same as the skin. So it's really important that we understand it's a different category. But the number one rule, I'm going to give you a few things to write down. The number one rule is that a mucosal pressure injury must always be device related. So if you look at, so where would these mucosal pressure injuries be? They're in moist body cavities with a device in it. So classically, we would see them in a nose from oxygen tubing or a nasogastric tube. It could be an ET tube, breathing, and then in the corner of the mouth. The worst ones, I think, are on the end of a penis from an indwelling catheter. It could be even in a stoma on the rectal tube was in there. So there are lots of devices that cause a mucosal pressure injury. But the word I want you to write down is device, medical device, because otherwise you could find a big white mark inside the mouth, and it could be a mouth ulcer, and people might start calling them mucosal pressure injuries when it is not. Okay, so it must always, the guidelines have been very clear, it must be device related. Now, in 2016, when the Americans got together and announced that they are now going from pressure ulcers to pressure injury, I actually got up and said, well done, America, good work. But just remember that it was the Pan-Pacific, Australia, New Zealand, Hong Kong, Singapore and China that moved across to this in 2009. But good work, guys. And but they actually wanted to create an 8th category called medical device pressure injury. Now, that has not had global acceptance. And I got a bit confused because if a mucosal pressure injury must always be, what was the number one rule with it? Must always be device. Well done, take care. So how do we have a mucosal pressure injury must always be device related, and then we create an 8th category, which is device related. So that's still working. People are working on that, but at the moment Australia has got the 7 categories, and so what I've done is actually created like a flow sheet which talks about 4 + 2 + 1, so we can all understand that it's different. What I will say to you, one of the things I want you to really pay attention to is that globally, well, nationally, we're not, after all these years, we're still not good at staging pressure injuries. About 30% of them are not staged correctly. And we're often calling everything that's red a pressure injury. So what we also need to understand is that because of research, we now have introduced new terminology. So if we look at some of those terms, MASIs and MARIs. So a MASI is a medical, a moisture-associated skin injury, and there are 4 of these. So it's incontinence-associated dermatitis, intrateginous dermatitis, 2 skin folds coming together with friction and moisture causing these reddened areas, classically found under the breast or in the abdominal cavity from the pannus. Peri-wound, with peri means around, so around the wound you get that reddened area, and peristomal. So there's 4 categories of MASIs. Now, what I want you to write down is the term cause. We know a pressure injury is typically, the number one enemy is shear and pressure. But if you look at incontinence-associated dermatitis, the cause is urine and feces. Intrateginous dermatitis, which I know Natalie from K-Care actually has the link to that. So if you want to contact her, she can send you the link. It's a global link to the guidelines. So it's caused from the 2 skin folds coming together, causing a whole lot of heat and moisture and friction. That is not the cause of a pressure injury. So we need to understand all these reddened areas now have names, and it's really important that we understand this, because the government has recognised that pressure injuries are actually quite avoidable, and therefore we're getting penalties around when we have these facility acquired pressure injuries. We need to be doing something about it. And if you call everything red a pressure injury, you're going to get into a lot of trouble. So getting back to what are the changes, I think some of the really big changes, the biggest change is that they've now recognised that the number one cause of a pressure injury isn't pressure. What it actually is any of you girls going to tell me?
Shear.
Yeah,
we've been hanging out with you long enough, Tracy, to know that it's shear.
Yes. So it's really important to understand the impact of shear. And this is, you know, for example, when you're sitting your patient, resident, client up to have their breakfast, lunch or dinner, they're upright. We know there's a lot of pressure on their bottom, but the forces of gravity are pushing their skeleton down the bed. And I want you to think about one little cell at a time. So each cell has a little skeleton around it. And that cell, through the forces of shear, is getting crushed, broken, bent, and distorted. And that cell is getting broken. So to try and make this a little bit more memorable or interesting, depending on how you interpret it, I want to take you back to the Star Wars movies, and you're in the chicane, you're driving through in your little spaceship, there's all these laser beams hitting you, your force field's breaking up, pilot's got to get out, and then boom, off he goes. This is what's happening to these cells when they're under the pressure of shear. The little cell, the skeleton gets fractured, the mitochondria who's driving the cell vomits out the cell and poisons the surrounding area, and that answers the question as to how did that little pressure injury become this massive big injury. So that's really important when we go back to what are the changes. The question was, what are the changes? The number one change is that the pressure injuries, number one cause is from the work of Professor Geffens, is shear. So when we look at the definition, the term localised is still there. So pressure injuries are not like a drug reaction where you get a big red rash all over your whole body, a case of the measles where you've got spots everywhere. A pressure injury is a localised area of damage, and the other new change is that within the definition is the term medical device. So we really need to make sure that we understand the causes of medical devices, and what makes them different is we can't just remove a medical device. So if we look at something like an ET tube, so a breathing tube attached to a ventilator, you've got to prepare the skin, and you've got these tight tapes on that hold that ET tube down your throat intact. If it's too loose, it's going to fall out and you're going to cause a lot of problems. So the preparation for the skin is protecting the skin with a you know, whatever you want to call it, Cavalon, and then a protective dressing so that those tapes aren't cutting into that mucosal area inside the mouth. And then the big trick with that then is making sure that your facility is doing this the same. So if theatre's prepping the patient and then they go to ICU and then they go to the ward, you need to make sure you're all doing the same skin preparation to prevent these avoidable pressure injuries. You can't avoid the ET tube, it's there. And that's the query behind the medical device related pressure injuries is we can't just remove the medical device. We've got to learn to work with it. Or working with the company is sometimes we can look at, for example, a nasogastric tube. Can we use a softer, more pliable tube rather than a hard one? Are you preparing around the nair? Are you protecting that? Are you moving the position of the nasogastric tube regularly so it's not always pushing up against the same angle of the nose all the time? So medical device related pressure, that's probably a half-hour talk, and we've only got 20 minutes today. And all I'm doing at the moment is introducing changes. So remembering that there are lots of reddened areas that are not pressure injuries. Number one, understand the cause. Second thing is there are a lot of penalties now around pressure injuries, so you need to make sure that you understand the staging system. Around about globally, nationally I should say, our pressure injuries are not being staged correctly in about 30% of them, despite decades of education. So that's why, again, I want to thank K-Care for making today possible. Even though we're not doing an in-depth reflection on how to stage a pressure, we're still talking about a lot of key factors you need to know to avoid misdiagnosing pressure injuries. So in summary, understand the cause of what causes.
Why do you think that is, Tracy? Why do you think that is, with all of the education that we've had around this, that people are still not understanding or being able to identify the cause or classify it correctly?
I think that we haven't had enough of this really simple education like we're doing today, which is when you asked me to be involved, and this is why I was on board the ship as quick as possible. And I really want to thank you again that you two had the vision and the hope. You're not out there, I don't know whether I'm allowed to say this or not, but you're not there, you didn't ask me to present any products. All you wanted to do was support your clinicians. Yes. And that's, if we want to use our product correctly, we need to understand what we're trying to, injuries we're trying to avoid. So well done, K-Care.
Excellent.
That's exactly it. So okay, so my takeaways from what you've said. So if we understand the cause, so if it's shear and pressure, we're looking more at pressure injuries. If it's moisture, it's MARSI. If we're looking at medical adhesives, so like the how we've strapped on something or whatever, that's a MARI. MARI, yes? I'm getting it right, but we haven't interrupted me yet. And if it's mucosal, it's a medical device related, has to be medical device. So if we can narrow the cause, then we can narrow down where we're looking then to stage it. And then if we can stage it correctly, which we can maybe get that in more detail in another session, who knows, but then we can figure out how we prevent it or how we treat it.
That's exactly where I wanted you to go. Thank you so much. You did a much better presentation than I just did.
No, I'm listening to you, and I'm like, I'm writing it down, and then you know when the penny drops for you. That's all. So
yes.
So you went exactly where I wanted to go, which is let's get all the names right, so our documentation is right. But in reality, if we understand what's causing this injury, we will then treat it correctly.
Yes.
That's really the thing. So the treatment and the prevention go together. Prevention's the big thing, and your government knows that pressure injuries are mostly preventable, and that's why we've now got penalties attached to them.
Yeah.
We're all being measured. We're all being compared nationally, and they're saying, why have you got these?
Do you know what? And the most important thing is if we can get this right, the person who we're treating, they're going to get a better health outcome. It's all for them. So
that's so important.
That's absolutely vital, and I can tell you, whatever your patients have come in for, if they get a pressure injury, that's all they talk about. And sometimes for generations, 3 generations, they'll be talking about, you know, people die of pressure injuries, people lose their legs from pressure injuries. You know, they'll often talk about, you know, I've seen people have bypass surgery, they've had their sternum cut in half, they've had their leg cut from their groin to their ankle, and they're not talking about that. They say to me, this little sore on my bottom is so painful. That's what they're really what's bothering them. And then, just as importantly, impacting on their rehab. So most important thing is that we understand what's the cause. We get our documentation right so we can communicate with the next shift what's going on and get the prevention and treatment correct. And I don't know whether I'm even allowed to say this, but if things go wrong, the first thing the coroner's going to look at is what was your risk assessment and what did you do about it? What did you do about it is the key. Your management plan and what did you do? And another thing I don't know whether I'm allowed to say, I was a patient last year for 9 weeks, and really that whole standard around consumer engagement, I now understand why it was so important. I just needed people to talk to me about my care, and I don't know whether you're all sitting on chairs because you might find it quite funny, but here's me who brought in an alternating device into this country, and I was on it, and it was all set on the wrong weight. You know, and I kept saying, could you please turn it down? It meant I couldn't sleep. I hated it, and in the end asked them to remove it. And I've been the nurse that's always trying to get the patients on them. And all I needed was someone to engage with me And it's really important how you look at someone when you're talking to them, how you repeat back what they've told you so they know that you understood what they said and that we're working in a team. And this is what your government's asking for. And that's what your accreditation is going to be really looking for, is how much did you work with the patient in the involvement of their care. So trying to get them to understand pressure injuries, we need to understand the big picture so we can explain it simply, which is why I'm so excited about what you guys are doing today. A short, sharp education session. And thank you for everyone that turned up, because it's pretty fun, really.
Oh, it is actually.
It's always fun with you, Tracy. Always.
So no, thank you. I think you really summarised it well. So, and like I said, the penny finally dropped for me. So I can't wait for the next session.
Yes, that's right. We're going to be uploading this onto the K-Care YouTube site. So everybody, if you want to join and become a member of and follow the K-Care Healthcare YouTube site, that would be fantastic. And it will also notify you of the next exciting chapter of Pressure Points on K-Care Chat with Paula and Nat and Tracy. So looking super.
Yeah. You know what? I thought the Matildas were good, but you guys are just incredible. I think it's so good to see. Well, I've got to say, two fantastic women really doing everything they can to help globally a big problem and support their customers, which is just amazing. At no point did you ask me to try and sell product. So I think just the fact that you want to get out there and support your clinicians is amazing. So I thought Matildas were good, but I'm just in awe of you two girls, and thank you, K-Care, for investing in this, and thank you for everyone that made the time to link in with us. It's just fantastic. Go Australia, you're incredible.
Thanks, you, I'm blushing. Thank you, Tracy.
Make that 3 women.
Yeah. Yes,
anyway,
exactly.
Looking forward to catching you up next time, catching up with you, okay? Thanks,
Thank
Tracy.
you very much.
See ya. Bye.